Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the retention of urine. Retention of urine may be either acute or chronic. The chronic retention leading to retention with overflow. Acute retention is never unheralded except in operative and traumatic cases. Otherwise, it may be acute retention over chronic. It is rare in children and females. Causes in males: prostatic enlargement, urethral stricture, post-operative retention. In females, retroverted gravid uterus, disseminated sclerosis and hysteria. In male child, meatal ulcer with scabbing. Others, following spinal anesthesia, blood clot in bladder, rupture of urethra, injury or disease of spinal cord, fecal impaction in the rectum, acute urethritis or prostatitis, phimosis, drugs and muscular atony. Clinical features: the patient is unable to pass urine. The swelling caused by full bladder can be seen in thin persons in the hypogasia. It is tender to palpation and dull to percussion above the symphysis pubis. Spasms of acute pain occur periodically as the bladder muscle contracts. The cause of retention is to be elicited. May be vascular engorgement of already engorged prostate, induration in the floor of the urethra in stricture, reflexes in lower limb and perineal sensation tested. Treatment: the patient must be confined to bed immediately and kept for 24 hours after relief has been obtained. Blood urea is estimated. Once the patient is accustomed to surroundings, the effect of administering omnipod to relieve anxiety and a hot bath to diminish internal congestion is tried. In many cases, the patient is able to pass urine into the bath. If this fails, catheterization is tried under aseptic measures. If urea level is raised, the catheter is left indwelling. A shave of pubic hair before catheterization facilitates the retaining the catheter in position with strapping. A small pre-sterilized plastic catheter called Jacques catheter is employed. If this fails, a Tiemann's hard rubber catheter is tried. If the catheter is to be left indwelling, a Gibbons catheter or a small Foley's catheter is to be used. If this fails or the case is of enlarged prostate, a large bicod gum elastic catheter is tried. If the case is of urethral stricture, a gum elastic olivary catheter is to be used. When the catheter passes the obstruction, the bladder is emptied completely. If after all attempts with the catheter fail, the alternatives are suprapubic puncture. It is done with a lumbar puncture needle or an intercath. Is a good method to relieve the acute retention. If the bladder is allowed to refill after it has been punctured, leakage into pre-vesical space is followed. Suprapubic catheterization, Rich's technique. An incision of half an inch is made under local anesthesia in the suprapubic region, and a catheter is inserted into the bladder 1 inch below the level at which anterior surface of the bladder curves upwards and backwards to form the dome. The fibers of linea alba are divided in the length of the incision. After the special catheter has been mounted on its introducer, it is passed through the incision until its sharp point touches the surface of the bladder, and the instrument is passed into the bladder with a short thrust directed backwards and downwards. The introducer is removed and the advancer is passed down the lumen of the catheter, and its expander is opened. So the catheter is carried towards the trigone and the advancer is removed. A stitch secures the catheter to the skin and is reinforced with a strip of adhesive plaster. Immediate prostatectomy. In fit patients with benign prostatic enlargement, immediate prostatectomy is considered. Urethral instrumentation. In case of urethral stricture, dilatation at regular intervals is a satisfactory treatment. Chronic treatment. Here the distension of bladder is painless. Bladduria is estimated before any attempt to relieve the retention. If it is below 70 milligrams percent, which is normal, the treatment is as it is for acute retention. If above 70 milligrams, slow decompression is advised. Slow decompression can be obtained by joining such a catheter to a bottle and arranging the end of the inlet into the bottle at such a height 7 to 10 inches above the pubis, so that urine flows over when the patient coughs or moves, thus raising patient's intra-abdominal pressure. The bottle can be lowered 1 inch every 4 hours. Retention with overflow. Here the patient has no control of his urine. Small amounts of urine passing involuntarily from time to time from the bladder, which is distended to its maximum capacity. Treatment is same as above methods. Indwelling catheter and closed system of catheter drainage. If a catheter is in situ for 5 or more days, urethritis is likely to supervene, which is reduced by using catheters made by non-irritant plastic substitutes for rubber. The incidence of ascending infection is reduced by connecting the catheter to sterile tubing connected to a sterile bottle and employing irrigation if clot retention occurs. To change the catheter in presence of urethritis entails a grave risk of infection from anterior urethra to the posterior urethra and to other parts of the urogenital system. Special forms of retention of urine. Post-operative retention of urine. In operations like anal canal, perineal region, on pelvic viscera, retention is so common that inserting a catheter before or after the operation. An elderly male prostatic obstruction should be suspected. Many patients can't urinate while lying or sitting in the bed. Another important cause is the sedation. When a sufficient quantity of an analgesic drug to relieve pain is administered, desire to pass urine is suppressed till the sympathetic nerve fibers are stimulated by over distension. Treatment. If the male patient supported is permitted to sit on the edge of the bed, he is able to empty the bladder. The sound of running water is helpful to stimulate the micturition. Parasympathetic stimulating drugs like carbachol may be prescribed. After trial, if the patient can't pass urine, catheterization is a must. Acute retention due to drugs like propanethylene bromide antihistamines, antihypertensive drugs, anticholinergic drugs, INH may produce acute retention and relieved after withdrawal of the drugs. Retention due to lesions of spinal cord, complete or incomplete lesions of spinal cord induce or precipitate retention. Atonic neurogenic bladder. Immediately after an injury, the detrusor muscle paralyzed sphincter vesicae contracts and sphincter urethrae relax. In lesions situated above S2 to below D6, due to sympathetic innervation, the bladder is intact, can appreciate when the bladder is full. Lead to paralytic overflow incontinence. This stage due to spinal shock may last for months. At recovery of shock, automaticity or autonomy of bladder function occurs after passing two stages: a phase of ineffectual emptying contractions. Contractions of detrusor muscle occurs, but as sphincter vesicae remains in spasm, small quantity of urine only is avoided, frequently for a few hours. Phase of hypertonicity. The detrusor passes into spasm, the sphincter vesicae relaxes physiologically, and sphincter urethrae refluxly. Automatic bladder or reflux bladder. If the lesion is situated above the center of micturition, the bladder empties reflexly every 4 hours. Residual urine may vary. When the filling reaches certain point, detrusor muscle contracts reflexly, a condition similar to infancy. Autonomous bladder. If the lesion is situated at level that will destroy the center of micturition or in the cauda equina, emptying of bladder depends upon precarious and inefficient control by the nerve fluxes present between the muscle strata of bladder wall. The result is the continuous dribbling, but the bladder can be emptied by manual compression. Residual urine is present, and dilatation of ureters reveal pelvic and calyces results. Treatment. A catheter of vortex tubing 1.5 millimeters in diameter, which is so designed that it can be retained by its wings in both male and female. The tubing is introduced at the earliest possible time, as there is evidence that over distension prejudices the eventual development of detrusor contraction. Important is early drainage in females, for otherwise wet beds favor the development of the. If tubing becomes blocked with mucus, it can be freed by suction applied with a syringe and needle to its distal end. Fluid intake of about 3 liters in 24 hours is recommended. Antibiotics if there is infection. State of automaticity. It is heralded by return of vulvocavernous reflux and anal reflux, and if catheter is blocked, urine is passed alongside the catheter. With the return of detrusor activity, bladder training is commenced. The catheter is clipped first and released at regular lengthening intervals. Later, the catheter is removed and reflexes are initiated by the patient lifting himself in chair or bed, again at regular intervals, by the clock. Drinks are given during day, but none after 7 p.m. Enhancing automaticity in refractory cases. Cystourethropy is invaluable in determining spasm of sphincter vesicae, contracture of prostatic urethra, prostatic shelf obstruction, and spasm of sphincter urethra. Transurethral resection of narrow strips of vesical neck and prostatic urethra between 5 to 7 o'clock is often successful in types of obstruction of 1, 2, 3 pudendal neurectomy, sometimes abolishes the spasm of sphincter urethra. Procedure. The patient is placed in jackknife position. Pudendal nerves are exposed as they leave the hallux canal and resected. If it is not successful, endoscopic resection of a portion of the sphincter urethra will be successful. State of autonomy. Manual expression of urine by the patient and contracture of the abdominal muscles is the only method of avoiding lifelong urethral suprapubic catheter. Persistent retention of urine following excision of rectum. In many cases, the retention of urine can be cured by transurethral resection of prostate. Usually, the prostate is not enlarged and consequently the resection can be carried out easily and quickly. Therefore, if after 2 weeks the patient is unable to empty the bladder and general condition is satisfactory, transurethral prostatic resection should not be postponed. That's all about the retention of urine, and in the next video I will discuss about some other disease. Thank you.